Dear colleagues, good afternoon. I would like first to thank Professor Diamandi for inviting me to this very important workshop. In the next 15 minutes, I will try my best. I will present you the benefits and risks of menopausal hormone therapy. I think you can hear me. Okay. So, as you all know, menopause is a permanent cessation of menses due to the ovarian follicle exhaustion. This leads, of course, to the loss of reproductive function, but the most important consequence is the estrogen deficiency. So all the consequences of menopause have their origin in the deficiency of estrogens. And what are these? The vasomotor symptoms or hot flashes and night sweats, urogenital atrophy, osteoporosis, but as well cardiovascular disease and mental changes, meaning mood disorders, depression, and dementia. So, in this context, in the clinical practice, we have three groups for prescribing hormone therapy. The first group is the women with premature ovarian failure or early menopause, women who are less than 45 years when their menses stop. The second group is the perimenopausal women who have menstrual irregularities, or those who are up to 1 year after menopause. And in the third category, we have the postmenopausal women. Concerning the first group of women, those with premature ovarian failure or early menopause, we have good evidence to support that women with premature ovarian failure have a higher risk of cardiovascular disease, of osteoporosis, of cognitive decline and depression, and premature death. And therefore, hormone replacement therapy should be prescribed to every woman, irrespective of the presence of climacteric symptoms. As we prescribe thyroxine for hypothyroidism, in that way we should prescribe hormone replacement therapy for ovarian insufficiency. And this treatment should go on until the age of natural menopause. In this point, I would like to present you a very recent review that appeared 2 weeks before in the JAMA Cardiology. They have made a systematic review and meta-analysis on 32 studies with 300,000 women, a very large sample. And they saw that women who experienced their menopause in an earlier age than 45 years had 50% higher risk of sustaining a heart attack and 23% higher risk of sustaining stroke and 20% higher risk of dying. So there is fairly good evidence that these women with early menopause will die earlier, so they need hormone replacement therapy. There are two groups, meaning the perimenopausal and the postmenopausal women. Here, according to current evidence, we have certain indications for menopausal hormone therapy. The presence of menopausal symptoms, the urogenital atrophy or the genitourinary syndrome of menopause, and the treatment of osteoporosis in this group of women who are symptomatic. In these women, in contrary to the previous group of women where we prescribe to everybody hormone therapy, here we have to carefully evaluate the patient to determine the timing of initiation, the duration of use. We have to carefully select the regimen with respect to estrogen dose, the type of the progestogen, the route of administration, and the mode of delivery, so that we have a maximal efficacy concerning quality of life, cardiovascular disease prevention, and osteoporosis prevention. And at the same time, we do not want to have clinically relevant risks, meaning breast cancer and thrombotic events. As I said before, the current indications for hormone therapy are vasomotor symptoms, urogenital atrophy, and osteoporosis. But I would like to show you some evidence that hormone therapy can also prevent other consequences of menopause, like psychiatric disturbances, sleep disorders, mood changes, and of course cardiovascular disease. Here is the preliminary composing of the interlaced study. This is a very, very big endeavor. There is a try to harmonize the data from 20 ongoing epidemiological studies all over the world. Here you see the baseline investigators. These are all the studies that take part around the world. And these are the countries who are represented, with a total number of women of 200,000 women. The preliminary results of this study were announced 1 week before in the World Congress of Menopause, and contrary to our belief that hot flashes and depression or sleep disturbances are two quite different things, here we see that there's a dose-response relationship between hot flashes and sleeping disturbances. The more hot flashes we have, the more sleeping difficulties we have. And the same exactly applies to depression. The more hot flashes we have, the more depressive symptoms we have. So by prescribing hormone therapy, we cure not only hot flashes, where we have a certain indication, but we also cure other comorbid conditions like joint pains, like sleeping disturbances, like depression, and we improve the quality of life of the woman. The second point where we have a clear benefit of hormone therapy in menopause is the cardiovascular system. Estrogen decline has both direct and indirect effects on the cardiovascular system. A direct effect is the arterial stiffening, endothelial dysfunction, chronic inflammation, while indirect effects are the increase in visceral adiposity, increase in insulin resistance, dyslipidemia, increased triglycerides, and of course all this will lead to early atherosclerosis and ischemic heart disease and stroke. We have today good evidence to support that women with hot flashes have an unfavorable cardiovascular risk profile, and it is this group of women, early postmenopausal women with menopausal symptoms, that will benefit the most in terms of cardiovascular risk prevention. They will improve their lipid profile, their body composition, their insulin resistance, and they will reduce the chronic inflammation. On the other hand, if we prescribe hormone therapy to older women who have already diseased vessels, then we may destabilize the plaque and cause an acute event. There are many studies to support this theory of the window of opportunity. For example, the Dobbs study, the Danish osteoporosis prevention study, a big study that was conducted in Denmark with 18 years of follow-up, has shown that women who started hormone therapy early in the course of their menopause had 50% reduction of total death and heart failure and heart attack. In the same line of evidence, in Finland, 500,000 women who took hormone therapy between 1994 and 2009 had definitely a coronary heart disease reduction between 18 and 55%, and they had an increase in life expectancy between 12 and 28%. And what was more important, there was a linear association between duration of use and magnitude of the effect. Last year, a Cochrane review was published with the same questions, whether hormone therapy can reduce the risk of cardiovascular disease. In the overall population, the answer is no. But in these women who start early within the first decade of menopause, yes, hormone therapy can reduce by 50% coronary heart disease and mortality by 30%. And the best evidence to support this theory is the publication of the ELITE trial 6 months before in the New England Journal of Medicine. This was a trial on 600 postmenopausal women who were randomized to receive either placebo or low-dose hormone therapy. And there were two. Those with early intervention, 6 years into menopause, and those with late intervention, more than 10 years into menopause. And they were followed up for 5 years. At the end of the 5 years, these women who started early their treatment had a decrease in the evolution of carotid atherosclerosis. There was a clear benefit, while the group that started late had absolutely no effect in terms of carotid atherosclerosis. So in this context, in order to provide benefit to our women concerning protection from ischemic heart disease, we have to select a high-risk group where we will not prescribe hormone therapy, older women older than 60 years of age or more than 10 years into menopause, or with long-standing, poorly controlled diabetes or clinically overt cardiovascular disease. And we have to identify risk factor for cardiovascular disease, for example, obesity or smoking or diabetes. To these women, we're going to prescribe transdermal hormone therapy to avoid the thrombotic effect. To all other women, we can confer benefit with respect to cardiovascular risk prevention by all types of hormone therapy. And now a brief description of the risks of hormone therapy. And I'm referring to two risks, breast cancer and thrombotic events. You are all familiar with these figures. These are studies from the last decade. Continuous combined hormone therapy, estrogen, progestogen therapy, standard doses for more than 5 years are associated with an increase of breast cancer risk of around 25 to 30%. How can we minimize the risk in the clinical setting? By two lines of intervention. First, we have to evaluate women, and then we have to select the regimen. Oh, sorry. Concerning the first point, there are some risk factors for breast cancer that interact with menopausal hormone therapy. And these are the low body weight. It appears that thin women are more at risk for breast cancer with hormone therapy compared to obese women. There are women who consume alcohol on a daily basis because it interacts with catabolism of estrogen, and are women who have very dense breast density. And we have good evidence to support that breast cancer risk is confined to these women with high breast density. On the other hand, there are risk factors for breast cancer who are, of course, applied to the general population, but do not interact with hormone therapy, like obesity, like a family history of breast cancer, low parity, or a personal history of fibroadenoma, for example. Concerning the second point, there are 5 issues which we have to take into account. First, whether we are going to use monotherapy or combine therapy with progestogen, because we know today that the risk is associated with the progestogens, not the estrogen. The duration of use, the type of the progestogen, the mode, whether it is sequential or continuous, and of course, the dose of the estrogen. So, in this context, we have to use the lowest effective estrogen dose. We have to ensure a low breast exposure to the progestogen. Preferably, we can give progestogen through the vaginal route. We have to select natural progesterone or dydrogesterone, which are breast-friendly. We have to use the sequential mode of administration because the overall exposure to the progestogen is lower. And of course, annually, we have to perform a cost-benefit analysis and to taper the dose of the estrogen. And I will close with the thrombotic risk. We know that there is an increase, small but statistically significant, of stroke risk with oral menopausal hormone therapy. And probably this has to do with the first-pass effect through the liver. The overall risk is small, but when we have risk factors like obesity or smoking, then the risk becomes appreciable. The same is true for venous thromboembolism. Oral therapy increases the risk, but here the increase is higher, 2 to 3-fold. And if there are thrombophilic mutations, then the risk is much higher. Today we have good evidence that low-dose thermal hormone therapy does not increase the risk of the thrombotic risk, either the stroke or the VTE. And moreover, the type of the progestogen has also an effect. Here you see the E3N study, the main study from where we derived our results. Increase with the low-dose transdermal estrogen in terms of thrombotic risk, and concerning the progestogens, the increase is mainly seen with a cluster of non-pregnant derivatives, while natural progesterone does not increase the risk. Furthermore, we data from the Million Women study, a large-scale epidemiological study, 1 million women in the UK, where you see the worst combination is the one used in WHI, oral estrogen plus medroxyprogesterone acetate, while levonorgestrel or norethindrone has a better profile. So when we prescribed hormone therapy in the context of venous thromboembolism, we have to take a careful personal history related to VTE. We have to see whether our woman is growing older or has a long menopausal age and other risk factors for VTE like immobilization or the presence of diabetes mellitus. If we have risk factors, then we're going to use low-dose transdermal hormone therapy, preferably with vaginal natural progesterone. In all other cases, we can use whatever type we like. And this is the slide, the overall principle of the use of menopausal therapy in menopause. We have to start as early as possible with low-dose hormone therapy, and very soon we will try to taper the dose to ultra-low dose of estrogen therapy. And as of the duration of use of hormone therapy, there's no time limit. This is a personal choice between the patient's physician and, of course, the patient herself. Thank you, and I hope to see you in our next Congress in Amsterdam. Thank you.